in these talks, I'm trying to cover a bit of basic sciences, bit of path, and obviously the clinical side of things as well. So paediatric knees, quite a lot to discuss. There we are. Extra-articular injuries, intra-articular injuries, fractures, and soft tissue. Okay, that's what we're going to divide it into. You know this, children, not small adults. The key thing is, you've got to start respecting the physes. You've got to understand periosteum, because sometimes it looks like a piece of tissue in itself. You want to think about when you want anatomical reduction, generally around the physes and around the joints. And you've got to think about long-term follow-up. So this is not the kind of patient you see at 3 months and discharge, okay? And just on a, if you ever think about doing peds, right? You are part of a triangle, sometimes a quadrangle, but certainly a triangle. So when you're in that room, you've got the kid, you've got to engage the kid, you've got to engage the parents, and you've got to interplay between them. It's a totally different consultation. It's totally different, okay? And you can't ignore the kid because they'll hate you. You can't ignore the parents because the kid can't tell you everything. So you've really got to understand how to deal with that, okay? Now, this is your basic science. 10 millimeters distal femur per year, proximal tibia. Most of the fractures account for, in terms of distal femur, proximal tibial physis, they account for 51% of partial growth plate arrest. So really, around the knee, you've got to be really careful, okay? Everyone knows this, I think. Salter Harris. Think about this. So your ones and twos, your physis is intact. You know that's, and to some extent 3. You know that generally the physis has not been damaged, but nevertheless, all of these really, apart from the 5, you need to reduce anatomically, or they need to be undisplaced. Always think if you've got this kind of injury, it's probably a reasonable energy of injury in a kid. And remember, the distal femoral physis contributes to 70% of femoral growth, 37% of lower extremity length. And don't forget the vascular structures in this situation as well. Now, associated injuries with these physes, quite high. And as I said, vascular and nerve injury. So this is a typical one, right? You need to get these plain films, but more and more. You can either get those CT, but I find MRI is pretty good actually these days. Particularly with the non-fat sat, you get pretty good anatomical definition. This is a kind of undisplaced one that you might reduce or not reduce, or just leave in a cricket pad split or a cast and mobilize quite early. You still want some imaging on this, right? You still want, and probably a CT actually, but you need to make sure it's undisplaced. Do less and less of this kind of thing, putting them in an above knee cast. But if it is a distal femur or proximal tibia undisplaced, very reasonable to put them in a cast. Now you can close, reduce, and internally fix percutaneously if you can get them across, but remember that comes back to the periosteum. Often the periosteum's in the way and you can't reduce it particularly well. You've got to be really confident that you've got a near anatomic reduction if you're going to do a closed reduction and percutaneous fixation. This is more like it, right? You're really going to have a degree of interposition in these sort of injuries. And you can do that. That's perfectly reasonable. 1.6 or 2 mil K wires, cross K wires, nice reduction, put them in a plaster. The new sort of orthopaedic sets are quite good, so they've got plates that can do the job as well. There's another one. So if you've got a Salter Harris 4, you reduce it open. You've got to make sure that if you're going to use anything other than K wires, you don't go across the physis. And here's another one. But you know what? These need a lot of following up. The hardware needs removal. You don't know when they're going to have growth issues, so you need to follow them up. Clinically, radiologically, So radiologically, what would you do in terms of following up? What are you looking for with this kind of thing?
So post-operatively, the reduction.
What about long term? Angular deformities. So how would you assess for those?
Sorry.
How would you assess for those?
Alignment, examination.
Yes, you do a clinical assessment, particularly coronal and sagittal plane lines. What else radiologically? It's long leg films, yes. How much radiation is involved in long leg films? A lot or a little? A massive field. Anything new that's come along?
Yeah, there's an EOS imaging system that they use at Bosch, which is
EOS is really good. I use EOS. There's much less radiation. So you don't have many EOS machines available.
Sorry, Mr. Gupta, what's EOS? I should have never seen one.
It's like somewhere in between a CT and an X-ray. And you get long leg films. Okay, so this is a nasty one. The Orthopaedics do plates now, which are quite nice. Got the idea with distal femoral. Proximal tibia, again, high energy trauma. Younger the patient, the more you can do this kind of thing. Cross pins, okay?
Are you also immobilizing them in plaster
Yes.
and doing pin checks at a week the same you would for supercondylar?
Absolutely. You've got to make sure you've got maintained reduction. This is quite nice. So you just do a sort of epiphyseal fixation. You've got to be really careful you're not on the physis. Now the issue is you could get bony bridges. This is the tibial tubercle avulsion. Easily missed actually, but it wouldn't be easy missed if you clinically examine the patient. What would they have? There, the back, yeah. Obviously, pain, swelling, bruising, what else? Yeah, they might, but remember this is massively displaced. They might do. Yeah, what else? Associated with that, what's the key finding? I mean, a lot of the kids have this.
Fusion.
Can't straight leg raise.
Can't straight leg raise. They've got a combination of this thing, just pain inhibition as well. Can't straight leg raise, big swelling. Think about that tibial tubercle. Okay. And again, think about associated injuries. So you're going to image these days. I think you've got to get MRIs. Okay. You shouldn't be just fixing these without understanding. Do we know any classifications for this? Ogden. So there we are. There's Ogden. I had one of these when I was at Hillingdon. Actually, I didn't have a clue what I was doing. I suggest just get on. Okay, but really, you really need to understand this. And the one I had was actually like that, right into the joint. This is one we did. Is this one? Yes, it is. Anyway, yes, so he was jumping around at one of the festivals, actually. So, you just want to... That's some nice intraoperative pictures, but really nice intraoperative picture of the periosteum in here. There's no way you could reduce that. No reduction. Take the periosteum out, put the screws in. Ideally, you want bicortical, right? This kind of thing. Yes?
Do you have a situation where you image the other side? Because in a pediatric population where you over-compress this when you fix it.
Anytime you're in doubt, you image the other side with kids. Is it fractured? Is it not fractured? Is it displaced? Is it not displaced? Image the other side. Patella sleeve. Oh, I've got some nice pictures of them. They are not benign injuries. So because the tendon is attached to this thing here. If I can, I'll download the pictures, the most recent one I did. But this is not a benign injury. This is not an undisplaced fracture. This is a massively displaced periosteal sleeve avulsion. Okay. So it needs fixing. Yeah.
I saw one of these. There was the MRI reported it as completely undisplaced. He had an intact extensor mechanism, then didn't turn up to his. I booked him a follow-up appointment, never turned up, called them, still didn't. Like, would you want to fix that even if it's like undisplaced and less extensor?
No, if it's undisplaced, it's fine. But no, I'm talking about this particular plain film. So this plain film's got two little flecks here, patella alta. So this is a displaced fracture. This one is undisplaced. What else is there? So you can do that. I don't like using screws around the patella. More and more I use anchors, cerclage.
I love suture tape. So either that with transosseous tunnels,
Yes.
and then but use all suture ideally, not
Transosseous tunnels too. I think it's really nice. Right, tibial spine avulsion. Anyone know this classification, or is there? Right. These are really, they're probably the most common intra-articular fractures. Okay. And you need to understand this. You need to understand that the ACL is attached to this thing. And once it's hinged up like this, it's really displaced. And either the ACL is going to heal with the ACL quite short and probably non-functional, or it's not going to heal at all. So these two need reduction and fixation. Anyone know how we reduce to fix them? Who wants to have a go?
So you could do arthroscopic assisted suture pass and then drill a tunnel. You could use a screw.
Well, if it's undisplaced, you might do this. All right, but less and less I do this. I mean, you can if it's undisplaced or less than 2 mils. Okay. This is displaced. Can you see that? This was quite a big fragment, but this reduced. Okay. That's quite rare. I generally do this suture fixation, but I'm going to show you a couple. So this one, yes, skiing. You can see her there. That is a Myers McKeever 2-3. Really, it's probably call it 2, but you know, on a plain film, it didn't look so bad, but clearly it was bad. We put a screw in, okay, because it was a big fragment. But again, this was 13 years ago. More and more, I use suture. Okay, so what you can do, you can use the root repair kit, or you can use a tibial ACL guide. In fact, I've got a lovely video. And you then, yeah, I'll show you a video. Okay, but what you want to, what's the thing? This is the anterior edge of it, right? What stops the reduction here? Yeah. Anterior intermeniscal ligament. This is something you talked about, isn't it? Intermeniscal ligament. Okay, so you've got to get that out of the way. So often, I'll show you the video. You need to debride it. Make sure you've done. It's not the end of the world, okay, if you shave away the intermeniscal ligament, but you don't want to. Okay, so you want to just debride it. You want to burr it down. You want to get a nice bed, nice bleeding bed, and then I actually often reduce it with a K-wire. So, generally pretty good. I've seen a couple of second opinions, I think I've one myself, where they've lost a bit of extension. Okay, and they can lose extension, A, because of a non-reduction or a redisplacement, but actually, sometimes you just get exuberant callus and fibrosis. And actually, the thing to do is go in and you can kind of, you can be careful at the base of the ACL, but often if you just do a lateral notchplasty, they'll get that extension back. Okay. Right, intra-articular, ACL. I am on a campaign and I will succeed. Any kid with a swollen knee after a trauma must have an MRI. Okay. There is, by definition, an injury. Why would you not want to know? It's crazy. Right? So we are going to get to a stage where everyone gets an MRI or a large effusion after injury, not infected, right? So really, it's non-contact, often with the knee with the foot planted, external rotation valgus. I'll show you some videos. Right, so talk about ACLs. We're talking maybe 50% of children with traumatic knee fusions may have ACL. I think that's probably slightly high, but I think 30% would be about right. We're seeing a lot of osteochondral injuries recently as well. Okay, why are we getting a higher incidence? There's no doubt we've got an epidemic of ACLs in children. Why? Well, they're bigger, they hit harder, they have more intense sports, and probably we're detecting better. More awareness. So there's lots of reasons. Okay. Not only do you get mid-substance, you get avulsion fractures from the femur, avulsion fractures from the tibia, we've already talked about. You also get partial injuries. Partial injuries in adults are quite unusual, but in kids they can have partial injuries. Most of those partial injuries actually heal. So you need to be aware of that.
Sorry, by that you mean one of the bundles?
Yeah, one of the bundles. Or sometimes you just get this kind of intra-substance stretch. You just get signal, but they're still intact. I generally don't
Do anything with it?
No. So this is an interesting one. So yeah, here's your PCL. What's this sign called?
Sickle sign?
Sickle sign or shepherd's crook. Or what's the other one? There's another one. But basically, it's really buckled. That is because the tibia is subluxed anteriorly, so the PCL is not under tension. And it's subluxed anteriorly because there's no ACL here. In fact, this kid has congenital hyperplasia of the ACL, but the point is you get no signal. That was his other side, congenital bilateral hyperplasia. And this is what we talked about earlier with some of you about axial views. You can just see this sort of signal around the ACL. So this is a femoral type avulsion of the ACL. Certainly, ACLs come off. Complete rupture of the ACL in children need reconstructing, okay, unless they're really young. Complete ruptures of the ACL in children need reconstructing. Why? Someone mentioned it earlier. Increased risk proven of meniscus tears. Okay? Increased risk proven of re-injury. Does not mean that they must have it, because on an informed consent basis, the parents might say, I don't want to. Okay? But in general, the advice is for the ACL to be reconstructed by an appropriate qualified surgeon, appropriate unit. That's not a have a go. Okay? Because, there we go. Paul Aycroft was a surgeon at Chelsea actually a long time ago. So, and lots of other papers, okay, showing poor results with conservative management. Okay, so the next question is, what graft do you use? I think the key thing is, are they skeletally mature or not? Okay, if they're skeletally mature, you could treat them as an adult almost. Okay, so you could use BTB, you could use hamstring, you could use quads. Never ever use an allograft unless it's some kind of weird multi.
Is that the same even if the child is like really hypermobile?
Yes. I've done it, I'm afraid. You know, the thing is, you kind of do it, you're around enough, you make enough mistakes. I once had, I remember it was like Christmas Eve. He came to me with his parents, he was 16. I said, he's got England trials for rugby in April. This was December. He'd got to go to England trials. He went there and lose his hamstring. He was a winger in rugby. I did an allograft. It was all fine. They were also self-paced. He only came for one follow-up, and then he just went off and did his own rehab. Re-ruptured. In fact, there was nothing there when we rescanned it. I think it just dissolved. Tunnels are fine. I never done an allograft in under 25 after that. And that's borne out in the literature, okay? Under 25s, allografts do badly. Unless you're talking as a multi-leg, okay? Right, so the other thing is you can do hamstrings, you can do transphyseal. I have lots of debates with my paediatric knee colleagues about this, but transphyseal is generally safe after the age of 11 or 12 years. You do it right. So what I call it physeal respecting, and it's now, I think someone took that term, it's in the literature now, okay? So who was I talking to? Right. Anyway, so I called it physeal respecting 10 years ago. Right. What I mean by that is here, this is not a great total position for an adult. Okay? Very vertical. It's transtibial. It's good on the lateral. It's where we want it to be on the lateral. Okay. Posterior aspects of Blumenstadt's line. But why do we do that? Why do we do that? This is actually a good.
It leads to smaller impact on the physis.
Yeah, because obviously if you go through something straight, you're going to get a perfectly circular hole. And the more oblique you go, the more oval the hole, the more you drill out. But what you do with this is you supplement it with lateral tenodesis, because you lose your pivot control with this. You do lateral tenodesis. Okay? That's the point. So that's, yeah, I think he was 11 actually. This is someone who was 16, 17. That's a more adult position. So you adjust your tunnel position based on the age of the patient and how much physis you want. This was an old technique. Right, key thing is almost hand ream. You want very slow reaming speeds. I always do it under image intensifier. God knows what's that doing to my lenses in my eye and my thyroid. And you don't want any hardware crossing the physis. Sometimes the tip of my screw just tickles the tibial physis, but it's not too bad. What about this? What's that? Sagont. Okay. Why is that important? Well, that's where the anterolateral capsule inserts, and this was the logic behind thinking about the anterolateral ligament and what happens outside the joint, because the sagom is associated with ACL. Now, you can preserve the physis. This is the Micheli technique, so what you can do is some form of, so you can take semi-T, you can pass it in under the intermeniscal ligament anteriorly, but not through the tibial tunnel, and then you pass it over the top at the back, so you're not drilled any tunnels at all. You can do the opposite by taking ITB and take it the other way in exactly the same manner. Okay, so that's the Cocker technique. All right, so you can do lots of things. You can also do all epiphyseal. So where am I? All epiphyseal, you drill a tunnel here, you drill a tunnel here. The tunnel length is about 15 there. I don't like all epiphyseal. Yeah.
Ms. Gupte, do you tend to use the Cocker technique as a temporizing measure for patients, or
Yes.
to get them to...
Six or seven, yes. But to be honest, you know what I've gone to? I've actually gone to doing an LET. So I had a 5-year-old who was a trauma, so he'd had a tibial mid-shaft fracture, so he had nails, flexible nails, with an ACL and a meniscus. So I actually did meniscus repair and a lateral tenodesis. All right. So you can, I think you can do what you, as long as you do it well. You've got to be careful about. The other thing is, even if you do this, you can still tether and you can still get a growth disturbance. The key sort of numbers are 9% physeal drilling. If you do any more than that, you get growth disturbance rabbits. Really, you want an 8 to 8.5 mil graft. Okay. I don't accept any graft less than 8 mil, probably 8.5 even in a 10-year-old. Talked about graft fixation. So actually, graft fixation, I need to talk on a bit, but double suspensory is what I do in the two kids. Don't have any of this. Re-rupture rates are high. I mean, in the quoted in the literature is 20%. I think mine's about 7%. Still a bit too high. But is it because they're more hypermobile? Is it because their graft's a bit smaller? Is it because they're non-compliant? They do have a higher rupture rate. Okay. Growth restoration less than 1%. Oh yeah, so she just had residual laxity despite an intact graft. You know, so these grafts can stretch out. That's kind of it, really. We should do meniscus tears at some stage as well, although we covered them with the adults. Questions? Quite a lot to get through.
You mentioned your mid-substance tears, but also if it was an avulsion from the tibial or the femoral side, would your treatment be any different if it was purely just an avulsion?
If it was a soft tissue avulsion, there is an argument for an ACL repair. The national guidelines are that if you're going to do an ACL repair, it should be part of the so poor. So the STAR trial's coming out, Steve McDonald's running it. They will be doing ACL repairs in over 14s and young adults. That'll be interesting.
I think it's a good idea in kids, in immature adults. My colleague has seen one, was going to do it, but then actually, before he came to clinic, he was actually fine. So he cancelled it. But I think there is a place for it. But I know there's the American Greg DeFleece who's pushing it forward in everybody. That's the wrong thing to do.
Is that the bear trial? The bear.
No, this is the American guy who's pushing it.
The Americans push everything because they make money
Off it, yeah. So he's pioneering as the thing, but I think that's probably wrong indication. But I think it's too early to tell. I think the STAR trial will be a very useful thing for us to be able to defend that role.
So there's been a lot of publicity about like, cross bracing for adults and stuff. Would you? Would you ever think that that's something that would go into kids?
No,
Sorry.
So Justin Rose, a surgeon from Australia, very eminent surgeon, he presented the cross bracing trial at Wexham meeting, and then apparently one of Alex Cross's minions had recorded the video of the lecture. Justin, sort of took it apart, saying it looks like it's not a great trial, loads of exclusions. The protocols just showed MRI healing of the ACL thing with it. And then he wrote a really nasty email to all of us to say that you've slandered this trial, blah, 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 blah. They got really upset with it. But the key thing about, I think, all of this, we talk about ACLs can heal, they can do things, but the key thing about ACLs is it's about functional stability. So if patients can't go back to playing sport or pivoting that they want to do, then they've got ACL deficient knee because it's not functional. So I think, you can do MRI scans to show that cross bracing can work and it does heal, but actually I want to feel their knee and pivot them. If I can pivot them, it hasn't worked then. So I think that's what the key thing they need to find out for it is. So, I mean, the cross bracing also is like, it's 6 weeks, flex knee and everything with it. Maybe not. If you ask a lot of people in soft tissue knee surgeons, they'd say you never flex the knee. You must always keep it in extension because you lose extension. Getting it back is really hard to get back.
I can't imagine compliance in this country.
Yeah, it is.
So Merv Cross, I knew him very well. He's just passed away recently, actually. He was a brilliant surgeon. He was a BTB surgeon. And his daughter, who's a physio. This is where we're a biased audience, right? We want to operate. But unfortunately, physios are biased as well, right? They want to treat everyone conservatively. I'm speaking about extremes. Of course, you've got good physios too. But, good business for them. Because they get repeat business they make thousands with conservatively managed knee issues, okay? So you've got to take a lot of stuff with not a pinch of salt, but you've got to take it very skeptically. If you get a surgeon saying you've got to operate on everything or repair works in my hands, right? Run a mile. If you get a physio saying there are, you should never operate on an ACL. Run a mile. Okay? So to be honest, I'm not qualified enough to talk about cross bracing. I've just not heard great things about it.
Is there any scope for ligament registries to give us answers to some of these questions?
We have one.
You have one?
Yeah.
We have one, the NLR.
But we don't.
There's no one uses it.
Well, because you were saying recruiting for RCTs and this is obviously really difficult, specific injuries, exclusions, all of this stuff. So, I mean, I didn't realise this was a bad topic.